Hello everyone, welcome back to Channel Essentials of Acute, Emergency and Critical Care. In today's video, we will discuss hyperphosphatemia, an electrolyte abnormality that is frequently encountered in nephrology, intensive care, oncology, and endocrinology. Although often overlooked, elevated serum phosphate can have significant consequences, including hypocalcemia, metastatic calcification, vascular calcification, and increased cardiovascular mortality, particularly in patients with chronic kidney disease. In the next few minutes, we'll cover normal phosphate physiology, causes of hyperphosphatemia, clinical manifestations, diagnostic approach, evidence-based management, and high-yield clinical pearls. Let's begin. Approximately 85% of total body phosphate is stored in bone, about 14% intracellularly, and less than 1% is present in extracellular fluid. The normal serum phosphate level in adults is approximately 2.5 to 4.5 milligrams per dl, 0.8 to 1.45 millimoles per liter. Phosphate homeostasis is regulated by three major organs: intestine, bone, and kidney. Three important hormones regulate phosphate balance. Parathyroid hormone, which increases urinary phosphate excretion. Fibroblast growth factor, 23, produced by osteocytes. It reduces renal phosphate reabsorption and suppresses vitamin D activation. Calcitriol increases intestinal phosphate absorption. The kidney is the principal organ responsible for phosphate excretion. Think of causes under four mechanisms. Number 1. Reduced renal excretion. This is by far the commonest cause. Examples include chronic kidney disease, acute kidney injury, advanced renal failure, hypoparathyroidism, and pseudohyparathyroidism. Remember, when GFR falls below approximately 30 milliliters per minute, phosphate retention becomes clinically significant. Number 2. Excess phosphate load. This may occur due to phosphate-containing enemas or laxatives, excess oral phosphate supplements, and vitamin D intoxication. Number 3. Massive cellular breakdown. Large amounts of intracellular phosphate are released during tumor lysis syndrome, rhabdomyolysis, severe hemolysis, crush injury, and severe burns. These are common ICU scenarios. Number 4. Intracellular to extracellular shift, seen in metabolic acidosis, diabetic ketoacidosis, and lactic acidosis. Initially, phosphate may appear elevated despite total body phosphate depletion. Hyperphosphatemia itself usually causes very few symptoms. Most manifestations occur because phosphate binds calcium. This produces hypocalcemia and calcium phosphate precipitation. Symptoms include perioral numbness, muscle cramps, tetany, carpopedal spasm, seizures, and prolonged QT interval due to associated hypocalcemia. You can check previous video on hypocalcemia. Chronic hyperphosphatemia can cause vascular calcification, soft tissue calcification, calciphylaxis, and coronary artery calcification. These complications significantly increase cardiovascular mortality in dialysis patients. Whenever you encounter hyperphosphatemia, evaluate systematically. Corrected calcium, magnesium, creatinine and EGFR, parathyroid hormone level, and vitamin D, depending on the clinical setting. Creatine kinase if rhabdomyolysis is suspected, uric acid and LDH for tumor lysis syndrome, and hemolysis markers if indicated. Remember to calculate the calcium times phosphate product. A value greater than 55 mg square per deciliter square substantially increases the risk of metastatic calcification, particularly in chronic kidney disease. Also remember pseudohyperphosphatemia, which can occur because of laboratory interference. Causes include hyperlipidemia, hyperglobulinemia, hyperbilirubinemia, and sample hemolysis. Always correlate clinically before initiating treatment. Treatment depends on the underlying cause and severity. Step 1. Treat the cause. Examples: correct acute kidney injury, treat tumor lysis syndrome, manage rhabdomyolysis, and stop phosphate-containing medications. Step 2. Dietary restriction. Limit phosphate intake to approximately 800 to 1,000 milligrams per day, particularly in CKD patients. Avoid processed foods, cola beverages, processed meats, cheese, and nuts. Step 3. Phosphate binders. If dietary restriction is insufficient, use phosphate binders with meals. Examples: calcium-based binders, calcium acetate and calcium carbonate. Avoid excessive use if hypercalcemia is present. Non-calcium binders: sevelamer, lanthanum carbonate, ferric citrate, and sucroferric oxyhydroxide. These are preferred in patients with vascular calcification or hypercalcemia. Step 4. Dialysis. Indications include severe symptomatic hyperphosphatemia, advanced renal failure, tumor lysis syndrome, and persistent hyperphosphatemia despite medical therapy. Dialysis effectively removes phosphate, although rebound may occur because most phosphate is intracellular. Before we finish, here are 5 ICU pearls. The commonest cause of hyperphosphatemia is renal failure. Always check calcium because symptoms usually result from secondary hypocalcemia, not phosphate itself. Tumor lysis syndrome and rhabdomyolysis are classic causes of acute severe hyperphosphatemia. In CKD, persistent hyperphosphatemia accelerates vascular calcification and increases cardiovascular mortality. Treat the underlying disorder first. Phosphate binders alone are rarely sufficient. Hyperphosphatemia is much more than just an elevated laboratory value. It is an important marker of renal dysfunction, cellular injury, and disorders of mineral metabolism. A structured approach: identify the cause, assess calcium balance, evaluate kidney function, and institute appropriate phosphate-lowering therapy can prevent serious complications and improve patient outcomes. Thank you for watching. If you found this video useful, please like, share, and subscribe for more evidence-based videos. I'll see you in the next video.